Assalamu alaikum. Now, today I would like to discuss about the Aspergillus. Aspergillus. Okay, Aspergillus or aspergillosis. It may be invasive and it may be chronic pulmonary aspergillosis. So it may be chronic pulmonary aspergillosis. In invasive aspergillosis, I goes with I. That means it happens in the immunocompromised immunocompromised patient. The patient who are taking glucocorticoid, the patient having neutropenia and HIV. HIV, glucocorticoid and HIV. The manifestation of invasive aspergillosis are there is a triad called fever, chest pain, and hemoptysis. Fever, chest pain, and hemoptysis. And for aspergillosis, invasive aspergillosis, if we do CT scan, we may get pulmonary nodule with halogen. Pulmonary nodule with halogen. This word is very high, halogen. And positive culture. Culture is positive, and there is a test called galactomannan test and beta glucan test. Beta glucan galactomannan test is positive. Treatment is voriconazole plus caspofungin. Voriconazole with or without caspofungin. So if I am summarize this, invasive aspergillosis happen in immunocompromised patient. There is a triad called fever, chest pain, hemoptysis, and positive culture. There may be positive cell wall biomarker and pulmonary nodule with the halogen. Treatment is voriconazole and with or without caspofungin. Now, chronic pulmonary aspergillosis. Chronic pulmonary aspergillosis. It is chronic. The risk factors in here: lung disease or damage, with or without cavitation, lung disease or damage, cavitary TB, more than 3 months, of weight loss, more than 90% patients have a cough, hemoptysis, and fatigue. So cough, hemoptysis, and fatigue. There may be cavitary lesion. With or without fungus ball. There may be cavitary lesion with or without fungus ball. And positive positive aspergillus IgG serology. Management is resect aspergilloma if possible. Azole medication. Resect azole medication, and embolization. If severe hemoptysis, embolization should be done. So resect aspergilloma, azole medication, and embolization if there is severe hemoptysis. So simple aspergilloma fungus ball in a pre-existing lung cavity is a form of chronic pulmonary aspergillosis but is usually quiescent with occasional hemoptysis. So that is all about aspergillus. I would like to discuss about some other. So if we like to differentiate between invasive and chronic pulmonary aspergillosis, invasive in immunocompromised, chronic pulmonary is pulmonary lung disease, lung damage. These are the risk factor. If we think about the manifestation one, in invasive, positive, culture, positive, cell wall biomarker, positive, CT, where we get a halo sign, and management is voriconazole with or without caspofungin. And in chronic pulmonary aspergillosis, more than 3 months of weight loss, cough, hemoptysis, there may be cavitary lesion, and positive aspergillus IgG serology, positive aspergillus IgG serology. Resect aspergilloma, azole medication, and embolization should be done. Now I would like to discuss about a very unique topic called Cryptococcus. It's a fungus, Cryptococcus neoformans. Actually, uh, Cryptococcus neoformans, mostly I remember it as it causes meningitis. So Cryptococcus neoformans replicate in the central nervous system and clogs the arachnoid villi. It clogs the arachnoid villi and increases the intracranial pressure. Brain imaging is usually normal, and there is enlarged as it blocks the CSF pathway, so there is enlarged ventricles. The diagnosis is made with lumbar puncture and on measurement of the CSF pressure, analysis of the CSF, and in the CSF and the capsular polysaccharide antigen on testing, or this one is very high yield India ink stain. This is a unique stain for diagnosing Cryptococcus neoformans. Patients frequently have fever, malaise, umbilicated skin lesion that resembles molluscum contagiosum. This one is another high yield. Then Cryptococcus may come with umbilicated, umbilicated skin lesion. Looks like molluscum, but it is not molluscum, it is Cryptococcus. A classic hallmark of hematological dissemination is the presence of skin papule with skin papule. This one again the high yield word for papule, skin papules with central umbilication, skin papule with central umbilication, and lesion may develop in the central area of hemorrhage and necrosis. Lesion may develop in the central area of hemorrhage or necrosis, central area of hemorrhage and necrosis, which is a diagnostic clue. Now, cryptococcal meningitis, I have already said it can cause headache, fever, malaise. It develops over 2 weeks. It develops over 2 weeks and can be more acute and severe in HIV. In CSF, there is a high opening pressure. What you will find in the CSF of a patient with cryptococcal pneumonitis: high opening pressure, low glucose, high protein, low glucose, high protein. WBC count is less than 50 micromoles per liter with a mononuclear predominance. Transparent capsules seen in India Inc. Cryptococcal antigen positive and culture on severed agar. Treatment initially is amphotericin B plus flucytosine and maintenance is fluconazole. Suppose suppose a patient poorly controlled HIV that presents with 1 week of worsening fatigue, headache, fever. Physical examination show bilateral papilledema, brain MRI is normal. Looks like cryptococcal pneumormans, cryptococcal meningitis, papilledema and headache represent increased ICP. So papilledema, headache represent increased ICP. Patient with HIV who have a subacute onset of low-grade fever, headache, signs of ICP should be evaluated for cryptococcal meningitis. So the patient, HIV patient, subacute onset low-grade fever, headache, and signs of ICP should be evaluated for cryptococcal meningitis. Okay, that's it for Aspergillosis and Cryptococcus neoformans. That's it.